to this week's Grand Rounds, starting exactly on time. Thank you, Steve, for rousing everybody up. I'd first like to acknowledge the traditional custodians of the land on which we're meeting, the Ngunnawal people, and pay my respects to their elders, past, present, and emerging. And I would particularly like to acknowledge any Aboriginal and Torres Strait Islander peoples meeting with us today. It's my very great pleasure to introduce Maansi Joshi, who's a staff specialist haematologist, to talk today. Maansi trained in Sydney in clinical and pathological haematology, managed to survive working with my sister and brother-in-law, for which she deserves great praise. She has done a postgraduate fellowship at somewhere called the Mayo Clinic, which I gather is reasonably reputable, and has a particular interest in haematological malignancies and plasma cell dyscrasias, and will give us an update today on multiple myeloma. So welcome, Maansi.
Thank you. Good afternoon, everyone. Thank you for coming. My interest is in plasma cell disorders and myelomas, like what Tim mentioned, and I will talk to you about myeloma therapies today. I will spend the first few minutes talking about where we were in the past and how our therapies have evolved. The bulk of my talk will be about what we do now, and a bit of insight into where this is going in the future. Some statistics from Cancer Australia. Myeloma is not very common. It's the 11th most common malignancy across the world and in Australia, and it forms less than 2% of all cancers. It's also the 11th most common cancer to kill patients. Patients who get diagnosed with multiple myeloma will eventually die of multiple myeloma. It is a treatable but not a curable cancer. It was described first in the 1800s, and we've come a long way since then to where we are now. The top of the black graph sort of gives you a little bit of insight into how diagnosis has evolved. Detection of Bence-Jones proteins was actually in the 1800s, and we still use it now for diagnosis, all the way to cytogenetic classification and using genes to better risk stratify our patients. Initial therapies that we used back in the day and novel agents that we use now, such as lenalidomide. Mollites osseum, as it was known as it was called back then, was first described in 1844 when a young woman presented with fatigue and bone pain. We know now that it is a malignant disorder of plasma cells, which are the cells in our blood that make antibodies. And so these antibodies, when they are clonal, are detected as abnormal proteins or M proteins. Sorry, I've lost one. In blood, which is how a lot of our diagnosis is done. Bence-Jones proteins were first described in 1845 by Dr. Henry Bence-Jones, and he remarked that it was a duotoxide of albumin. It wasn't until a decade later, in 1956, that two independent researchers found that the Bence-Jones proteins were actually two separate classes of proteins. The kappa and the lambda were then named in their honor. This is where therapy started, and I can only imagine if steel was used in the 1800s, that's how you would consume it. Steel, urethane, quinine, leeches, cupping, venesections was used back then. The quinine is actually a picture of Amazon. So if you want to buy, you will get this authentic bottle with the label that seems like it's come from the 1800s. I wouldn't recommend it, but if you did want to. In 1966, so post-war, an RCT was done to compare urethane to Coca-Cola, I think. And they found no difference in outcomes. And so it was dropped as a treatment modality. It was really in the 1950s where the chemotherapy era of plasma cell treatment came about. Various trials looking at the use of melphalan and prednisone were done. Other chemotherapy agents that were trialed were carmustine, cyclophosphamide, vincristine, and melphalan. There was a meta-analysis done in the late 80s, early 90s that kind of looked at combination chemotherapy and overall survival, and they noted that just using melphalan prednisone versus combination chemotherapy did not actually impact on overall survival. And so melphalan and prednisone remained the standard of care throughout the 50s, 60s, and all the way up to 2000. Autologous stem cell transplant to improve survival was first trialed in the 1980s. And as you can see, these two groups were essentially the high dose chemotherapy followed by a transplant versus conventional dose chemotherapy without a transplant. And the transplant improved these patients' overall survival. Transplant remained the standard of care for a long period of time. Despite the use of different sorts of chemotherapy and transplant, the overall survival in myeloma didn't really change very much. People only lived about 1 to 3 years at the time. And there was certainly a need to improve on therapies. And this is where sort of thalidomide came in the late 90s. And there's a really interesting story of how thalidomide came to be. Most of you may have heard that thalidomide was first marketed as an anti-nausea drug in pregnancy in the 50s. And it was an Australian physician who brought it to the authorities' attention that it is a teratogenic drug. Interestingly, it was only available in Australia and Europe as the anti-nausea drug. It wasn't approved by the FDA because of lack of data. But once we recognized that thalidomide was teratogenic, there were more studies and trials done to understand how the drug works so that it may be used in cancer. It was described that it was the anti-angiogenic property of thalidomide that helped in malignancies. And at the same time, there was a paper by a pathologist in America who described angiogenesis as one of the pathogenic features of myeloma. It was a patient's wife who called Dr. Balogi, who still remains one of a big name and a big researcher in myeloma. He works at the Arkansas University. So a patient's wife who liked reading literature read these two separate papers, and she rang Dr. Balogi and said, "Oh, well, my husband has now relapsed through every chemo line. Maybe you should trial him on thalidomide." And Dr. Balogi reluctantly agreed. He trialed 3 patients on thalidomide, and lo and behold, their M protein started to come down. That sort of kicked off the first clinical trial that was published in the NEJM, which is this one, of about 84 patients with myeloma, and showing how the M protein would beautifully come down with thalidomide. Thalidomide really kicked off the novel therapy era in treatment of multiple myeloma. So how do we diagnose and treat myeloma today? We'll get a bit of help from Mr. RW. We'll follow his journey to try and understand treatment of myeloma in this day and age. He presented, 53-year-old, who presented in November 2018 with anemia, elevated creatinine, back pain, and fatigue. He also had an elevated LDH. His paraprotein was noted to be 46 grams per liter and typed as an IgA kappa. He had elevated kappa light chains at 2,189 milligrams per liter. He had a bone marrow biopsy which demonstrated 50% plasma cells. FISH studies noted a gain in 1q chromosome. FISH is what we use for detecting chromosome abnormalities in malignant cells. He had an MRI skeletal survey, and it did not demonstrate any lytic lesions or myeloma-associated bone lesions. The IMWG, or the International Myeloma Working Group, defines myeloma for us. And it's really the 2 boxes in red are the people with myeloma that require treatment. If you have clonal plasma cells more than 10% with an organ damage, as defined by FRACP, so elevated calcium, abnormal renal function, anemia with a hemoglobin of less than 100, or bone lesions. It is these people with active myeloma that require treatment. People with so-called smoldering myeloma, inactive, i.e. inactive myeloma, don't need to be treated. Mr. RW clearly fell into one of these boxes. So he had 50% plasma cells. He had an elevated calcium level and impaired renal function. So hence he was treated. The RISS is a prognostic index we use in myeloma, and broadly these patients are divided into 3 stages, 1, 2, and 3, based on their albumin, beta-2 microglobulin, LDH, and most importantly, genetics. If all of these features are normal, they're in the stage 1 or low risk category. If all of them are abnormal, they're in stage 3, and really everyone else falls in between in stage 2, quite a broad set of people. As you can see, the survival curves are quite different. So if you were sort of stage 1 disease, you're likely to survive about 10 years or more. If you were stage 3 disease, survival is only about 4 or 5 years. So Mr. RW was an IgA kappa multiple myeloma, RISS3 with a GAIN1Q, which is considered a high-risk mutation in multiple myeloma. He was treated in 2018, so before 2020. So he received VCD times 4 cycles, followed by an autologous stem cell transplant with melphalan, and then went on to lenalidomide maintenance. As hematologists, and I think all doctors, we love our acronyms, and I'll tell you what they stand for in a minute. As I was saying, thalidomide sort of kicked off the novel therapy era in multiple myeloma, and from the early 2000s, we've had some really good drugs available for myeloma that have improved survival and improved response rates in the disease. So the first 2 to be approved were Velcade or bortezomib, which is a proteasome inhibitor, and Revlimid or lenalidomide, which is an immunomodulatory drug. And these 2 are still used in the treatment, in the first-line treatment and subsequent therapies in myeloma. After about 2010, there was an explosion of drugs available, which included second and third generation IMiDs and proteasome inhibitors, as well as, quite importantly, monoclonal antibodies such as daratumumab. More recently, since about 2020, we've had T-cell therapies available, and I will talk about that a bit later. So frontline therapy for myeloma, we divide our patients broadly into 2 categories. Are they transplant eligible? Are they ineligible for transplant? Ineligibility is usually to do with older age, frailty, and comorbidities. So if they are transplant eligible, we would advocate for a bone marrow transplant for our patients. Prior to a transplant, they will have induction therapy with now VRD. VCD was used pre-2020, but the standard of care has now changed. V stands for Velcade or bortezomib. R is the Revlimid or lenalidomide, which is the immunomodulatory agent. D is dexamethasone, which is a constant for almost every myeloma regimen. And previously, we also used cyclophosphamide. If these patients are not eligible for a transplant, they might get a watered-down version of the VRD, or we will drop the Velcade and just give them lenalidomide and dexamethasone. Now, where does that therapy come from? It's 2 trials really that dictate frontline therapy in multiple myeloma: the IFM 2009, and which was done in Europe, and the Determination study, which were done in North America. And they're essentially similar sort of trial designs. Patients received 3 cycles of Velcade, Revlimid, dexamethasone, followed by a further 2 cycles and an autograft, or a further 5 cycles of RVD. They then went on to lenalidomide maintenance. Maintenance lenalidomide is done at a lower dose. So if we use 25 milligrams for induction, we use 10 milligrams as maintenance. And patients remain on maintenance for a very long time, so up until they relapse or are intolerant to the drug. As you can see the curves here, so after about 7 years of follow-up, there was a nice separation of curves between patients who were transplanted and not transplanted. And the progression-free survival was about 4 or 5 years for patients who were transplanted, and about 3 or 4 years for patients who were not transplanted. Interestingly, however, the overall survival in these patients does not change whether you receive a transplant or you don't receive a transplant. And so people who choose not to have transplants, even if you're eligible, we do either delay transplants in these people or sometimes not do them, because again, overall survival is unaffected by bone marrow transplant in multiple myeloma. As it stands today, VRD with a transplant is standard of care in most of our patients. I say that, and then 6 months ago, we had a study that improved on the progression-free survival by using a drug called daratumumab upfront. So this is a monoclonal antibody which is targeted against CD38, which is a common antigen on myeloma cells. And it further improved progression-free survival at 5 years to 84%. Some mutterings at our recent conference last week suggest that these patients are potentially now surviving beyond 10 years, so 12 to 15 years is what the early data is showing us. So Mr. RW, he received Velcade with cyclophosphamide and dexamethasone because Revlimid was not available at the time. He had an autologous stem cell transplant and then went on to lenalidomide maintenance. He achieved a complete response following this therapy. Unfortunately, however, 18 months after his transplant, so approximately 2 years from the time that he was diagnosed, he had disease relapse. Relapse in myeloma is essentially a rise in the M protein, and we, at the time of relapse, don't wait for end organ damage to set in. If they've had a 5 grams or more rise in their protein levels, we will treat patients with myeloma to avoid the organ damage that we know will eventually happen. Novel strategies in myeloma. This just gives you, I don't expect you to be able to read all of them, but it gives you an idea of how much drug discovery has occurred in myeloma over the last 20 years or so. We use proteasome inhibitors, which is the Velcade, already in frontline and relapse therapies. And a lot of our drugs kind of sit here where they target the bone marrow microenvironment, immunomodulatory drugs and cell mods, monoclonal antibodies, and then more recently bispecific antibodies and T-cell directed therapies. So some of these newer agents, because we love our acronyms, are described here. There are multiple trials in relapsed myeloma which dictate which drugs we will use and how we will use them at the time of first relapse. I won't go through every trial because I would be a bit boring in this forum, but it just to highlight, there are drugs such as daratumumab, which is a monoclonal antibody, carfilzomib, which is a proteasome inhibitor, second generation proteasome inhibitor, pomalidomide, which is another cousin of lenalidomide or the immunomodulatory drugs, and selinexor, which have now become available in the last 10 years. We generally, at the time of first relapse, we will try and give them drugs that they haven't seen before, kind of based on this list. If they haven't seen a particular type of therapy before, they'll get one of these regimens at second line. We anticipate a degree of response, and they remain in remission, usually for a shorter period than they did at the time of their disease diagnosis, and they kind of cycle through subsequent lines of therapy. So one of the big things with multiple myeloma is once you start therapy, you're kind of always on therapy for as long as you live. So you will cycle through your first line of chemo. When you relapse, you'll get your next line of chemo. When you relapse again, you get your next line of chemo. And if you were alive for about 5 years from diagnosis, or 6 years, you would have been on some form of therapy or the other for the entire duration of your disease journey. So Mr. RW relapsed 2 years after diagnosis. At the time, he received carfilzomib and dexamethasone. This only lasted about 6 months, after which he relapsed again. At this point, he was enrolled onto a clinical trial and received pomalidomide, bortezomib, and dexamethasone. He achieved a very good partial remission, which is essentially 90% reduction in his myeloma burden. And that remission lasted about 12 months, or just under 12 months. He went on to another clinical trial at this point and received a bispecific antibody called cevostamab. Unfortunately, he didn't really have any response to it, or maybe he responded for 1 cycle, because 2 months later he needed to have his next line of therapy. At this point, he had daratumumab, lenalidomide, and dexamethasone, and then he had a second autologous stem cell transplant. He's currently on daratumumab maintenance. He receives the injections once a month, and he is in a very good partial remission, which he's holding. So this is approximately 2 years after he started his last line of therapy. As it stands on PBS, he probably has one or maybe a second drug that is available, and then that'll be the end of the road. Remembering he's only 57 years old. He's had lots of complications along the way, both as a result of the therapy and from his myeloma. He developed a right lower limb pulmonary embolism for which he's on anticoagulation. He's had multiple infections and is now on monthly IVIG replacement. He developed hyponatremia, NSI-ADH, after his second autograft that requires sort of managing. He had shingles reactivation along the way, CMV viremia, and neuropathy from some of his drugs. So he doesn't really, this 57-year-old doesn't really lead, I mean, normal-ish life with problems that he's had. So where is therapy for myeloma going? Some of you in this room may have heard about T-cell therapy, and the newer kids on the block really are the bispecific antibodies and CAR T cells. These are T-cell redirected therapies. And just for medical students in this room, as a basic premise of cancer, we think, is the failure of our body's T-cell immunosurveillance. So we think that it's the T-cells that are failing us, and therefore there is occurrence of malignant tumor cells that are escaping the immune surveillance. So these therapies are really designed to kind of reactivate or sort of get our T cells back into action to fight the tumor cells. CAR T cells, so CAR or chimeric antigen receptor, these are recombinant receptors that are sort of genetically engineered and then tagged onto patient T cells. The idea is to have rapidly generating tumor-targeted T cells. And once these CARs are expressed on the T cells, we think that these T cells become sort of gain superpowers to be able to fight tumor, to be able to detect tumor antigens and then kill the tumor cells. So these CARs have quite a clever design. They have an intracellular domain that sits inside the T cell. It's usually a viral vector that's used to infect patient T cells with this CAR. And it has an extracellular domain that can recognize tumor-specific antigens. So you have, for example, in multiple myeloma, BCMA or B-cell maturation antigen is a common antigen seen on the surface of plasma cells. So you will have this CAR that's designed to attack BCMA on the outside, with this where it sits inside the patient T cells. In a lymphoma CAR, for example, this outside ligand would be specific for CD19, and so on and so forth. That's how different CARs are designed for a specific tumor type in mind. When the CAR T cell binds with the tumor antigen, it activates other inflammatory cytokines with the help of natural killer cells, macrophages, etc. And it's the inflammatory cytokines that ultimately result in cellular killing. So what's the process? How are these manufactured? Blood is collected from the patient with apheresis. The T cells are separated. These T cells are then sent to a lab. At the moment for myeloma T cells, they go to a lab in California. They get genetically re-engineered with a viral vector to have the CARs infected onto them. They are then multiplied in a lab, put into an infusion bag, and then transported back to be infused into the patient. For multiple myeloma, this entire process takes about 2.5 months. And so you can appreciate that if a patient requires treatment quickly or urgently, this is not a quick process for myeloma. It is a little bit quicker for lymphoma. Bispecific antibodies are somewhat similar in the concept and different in design. So bispecific antibodies are off-the-shelf products. They have two prongs, one prong that binds to a CD3, which is present, which is a T cell marker and present on our T cells. And they have another prong that would recognize the tumor antigens. So for example, BCMA for myeloma or CD19 for lymphoma. And they kind of bring the T cell closer to the tumor cell. And we think that by allowing this recognition of the T cell, of the tumor cell by the T cell, there's induction of the accessory cells, i.e. macrophages, natural killer cells, dendritic cells, release of inflammatory cytokines, and tumor cell death. These are the two specific sort of T-cell redirected therapies that are available at the moment. Bispecific antibodies, like I mentioned, were off the shelf. It doesn't require any manufacturing time. CAR T cells are the patient's T cells that have been re-engineered to recognize the tumor. Bispecific antibodies, a lot of them are actually subcutaneous rather than intravenous. CAR T cells are mostly intravenous. And the idea is for basically our T cells to do all the hard work. One of the early studies in CAR T therapy for myeloma was the CARTITUDE-1. And I'm sure there's somebody who sits in a lab who comes up with all these names for both hematological, oncological, and I think even immunological drugs, just to make it difficult. Ciltacabtagene autoleucel, took me a long time to learn it, is a BCMA-directed CAR that was studied in a phase 1/2 study called the CARTITUDE study. Now, these patients have on an average received at least 5 to 6 prior lines of therapy. They're heavily pretreated, most of them quite frail patients. As a comparator, real-world analysis was done in a locomotion trial in the European population, where if these people were treated with standard available therapies, their overall response rate is only about 32% and survival of less than 12 months. When these people were given infusions of CAR T therapy, their response rate was nearly 100%, with at least 2/3 of the cohort going into complete remission. One of the problems with these T-cell directed therapies, as I mentioned, it's the cytokines and chemokines doing all the killing, is they have quite high incidences of CRS or cytokine release syndrome. So these cytokines and chemokines have off-target effects where they result in hypotension, fevers, and in some cases can even lead to death. There's an unusual neurological syndrome that can occur in about 20% of patients called ICANS. It's a neurological toxicity from these T-cell redirected therapies. The exact mechanism is not fully understood, but it is a problem with most T-cell directed therapies. And extreme cytopenias is also quite problematic with these therapies. Having said that, the response rates are incredible, and us as hematologists as a group are looking forward to being able to use them in more studies to help guide how we use them going forward. That was the CARTITUDE-1 study. I'll skip over CARTITUDE-2. They never did a CARTITUDE-3. I'm not sure why. So CARTITUDE-4 looked at giving this CAR T-cell therapy in patients a bit earlier. So because they had such good responses with heavily pretreated patients, the question was, what if we gave it earlier? Would we be able to cure the disease? As you can see, the curves separated beautifully with the response rate and progression-free survival in those who received CAR T-cell therapy really quite extraordinary. However, that separation only occurred after the first 3 months. And in fact, the people who received CAR T cells actually had a dip in their curve initially. And that's largely to do with turnaround time from CAR T cells. And these people who are really quite unwell actually may not be able to wait to receive their CAR T cells. And there's an initial mortality signal just waiting to get treatment. So although the results are really impressive, there is quite a lot that still needs to be ironed out with these therapies. Just moving focus to bispecific antibodies, there's quite a few in the works. Most of them have been studied in phase 1 and 2 trials. The target, as you can see in this top line here, is different. These are all directed against myeloma cells. BCMA is one of the most common myeloma antigen, and so teclistamab, which is currently approved by the TGA but not PBS funded, is BCMA directed. There's others called talquetamab, which targets GPRC5D. and then cevostamab, which our patient had. So there's multiple bispecific antibodies currently in phase 1-2 trials. Their response rates are also quite impressive. So in patients who are heavily pretreated, 5 or 6 prior lines of therapy, they have a response rate of over 50%, which is really quite incredible because we don't expect these people to survive any more than sort of 10 to 11 months. A lot of toxicity from T-cell directed therapy, CRS, as I mentioned, cytokine release syndrome, ICANS, which is a neurological syndrome we see from these therapies. Infections is a huge problem with these treatments. They cause quite significant cytopenias and B-cell depletion, which make people prone to sort of ongoing infections even after their treatment has stopped. Secondary malignancies, about 5% in some studies, actually 10% in one study. So there is also quite a problematic outcome that hasn't quite been nutted out. And financial toxicity. So although these therapies are currently not available, the estimate for one dose of CAR T-cell therapy for one patient is approximately $1 million. So very expensive still. Impressive results so far. Long-term toxicity still needs to be seen for T-cell directed therapy. The duration of therapy remains a bit unclear. With CAR T-cells, they are sort of a one and done, but with bispecific antibodies at the moment is an ongoing therapy. The $1 million price tag is for CAR T-cells, but as an example, we recently had a patient in our unit who received a bispecific antibody. It cost them $26,000 for 1 month, and that was only 4 doses. And so if you can imagine, these people are sort of on ongoing therapy. You'd sell everything you owned and you'd still need more money to pay for these therapies. So watch this space. At the Canberra Hospital, we're hoping, or we're aiming to be a CAR T center in time. So we will definitely have updates for you. We are hopeful that we will treat our first patient in 2 years' time. I say that while Maya's sitting here, she might correct me. With all of the changes in therapy, we have definitely improved survival in myeloma. In the 50s, when they used steel and urethane, the survival was less than 10%. As our therapies have gotten better, our survival has certainly improved. This is a curve in the Australian population. This is a curve from the American population. So the 5-year survival is still about 50%. So we can certainly do better. We've already done well, but we can certainly do better. And we look forward to changing things for our patients in the future. And with that, I will stop there, and I'm happy to take questions.
I'd like you first to join with me in thanking Maansi for that absolute tour de force in the development of treatment options for our myeloma patients, or your myeloma patients. Looking for questions, but in light of the your last couple of slides talking about the cost of the bispecific antibodies and CAR T, and the question of PBS subsidisation, I have sat on the PBS advisory committee in a past life, and it is you need the wisdom of Solomon to try and work out how to allocate a specific amount of money to what disease and what therapy. Can I ask, in terms of the very impressive results you've demonstrated with both CAR T and the bispecific antibodies, what's the quality of life given their toxicity? Did you get a sense from the studies of the quality of life of patients who have been treated?
So it's interesting actually, because one of the big problems with patients is a lot of the toxicity. And the CRS and ICANS are sort of acute toxicities that they have early on when they get their treatment. But really what gets people down is the recurrent infections and repeated hospital visits. With bispecific antibodies, we don't actually have an end date. So people who are on it, so for example, we've got a few lymphoma patients who are on bispecific antibodies. They come in once a month for their injections, and this is ongoing without an end date. These people, and particularly myeloma patients, are so prone to infections. At the moment, a lot of the patients who've had these therapies have been those who've been sort of, beyond 5-6 lines of treatment. And this expected survival is only about 12 months, if that. Not great, I think, is a short answer. Good quality of life. The studies that are ongoing right now are trying to bring these therapies in earlier lines to see if we can improve the progression-free and overall survival and make it like a one and done. So hopefully we think it'll be better if we treat them sooner with these therapies.
So are you treating, I mean, just asking a logistic question, given the expertise that's necessary in the management of these patients, I presume you're treating, surrounding New South Wales, and you have, as well as the ACT. You presented the data in terms of the epidemiology, well, the prevalence of myeloma is the 11th most common cancer. Do you have, and then issues with respect to the pathogenesis, but is the incidence increasing or is it stable?
It has gone up in the last sort of 30 years. I actually didn't put up that slide. I have that slide on there. I took it off, but it has gone up in the last 30 years. Now, is it because the general incidence of cancer has gone up? Because it's all kind of cancer incidence has gone up in the last 30 years. Or if it's something myeloma specific, I couldn't tell you.
Well, that was the follow-up question, because we know that, obesity is driving certain malignancies, breast, endometrium, etc. I was just wondering if there are environmental factors that have been identified, perhaps.
Not a specific one for myeloma that's been identified, but we know the incidence has gone up.
I'll just follow up on your question about CAR-T and PMAP. So silver cell has been to MSAC, it goes to
Yep.
And it's been turned down. I think some of the questions really about it were too. So it costs about $650,000. And it's not clear that it's curative.
Yeah.
And this contrasts with large cell lymphoma, where we have an approval for third line and a pending approval in Australia for second line, where it is curative in subsequent patients. And I think that's the issue that RT's frequent faces in myeloma.
There's one other issue with CAR-T that I was actually working with the TGA when this technology became available. It is how you actually not only regulate it, but specifically because of the expertise needed to treat patients, which centres in Australia were going to be able to administer the therapy and manage patients with CRS, etc. And that is something, I don't know whether the TGA is still grappling with this. But
well, there are 6 in Australia, 7 in Australia at the moment, but the indications have expanded tremendously.
Yeah.
So
well, that was always going to happen.
We are aiming to be a centre for the next 18 months. Just on the topic of CRS, the thalidomide syndrome, you will potentially see patients, the junior doctors here, who are on bispecific antibodies, either both in oncology and haematology. So I really would encourage you to learn about cytokine release syndrome and contact us if you have concerns about patients on, because these patients do need urgent anti-inflammatory modalities.
Thank you. Are there any other questions? Oh, yeah, sorry, up the back. Sorry.
Exactly my major that's one interestingly when he went he was kicked off the trial in the first month of but the Celostine has got a bit right, and he was actually sent back to Canberra and admitted to hospital with explained IVs. And we really tested a lot of it. He did have a CNG button in his mind, but it wasn't and in retrospect now, I wonder whether he actually was having a
CRS, yeah.
Reaction. Didn't have a drop, an immediate drop in power. So he had this sort of progressively being put sick with medium time. Actually, tumor mass itself to that time. Most of sort of in a way, then got low administration down to the psilocybin, which has been shown in some
mouse model.
Amazingly, he literally went straight into it. It's wild. Lights are pretty close.
Yeah.
Just understood. That's why I'm getting patients.
I was wondering how you got narrow index with BBS
I didn't.
Yeah.
And he didn't get any benefits. He took out one. So yes.
What was the logic said?
I might just, sorry to interrupt, but try to paraphrase for people online who may or may not have heard all of that, and it's way beyond my pay scale. But essentially, the comments have been made in respect of the patient who Maansi presented, how the bispecific or the combination bispecific antibody treatment and his response to that came about. And how it was funded, given the conversation that we've just had. Are there further questions? There don't appear to be anything online. Well, if not, if we could just thank Maansi again for a wonderful